So we're going to talk about some stone disease, urological stone disease. All right, not a lot has changed in kind of what's in Tent Alley, what's in Rosen's as far as workup, management, everything else. But when I was doing this, I took a little bit of time to kind of go through urology's kind of policy statements and their guidelines and requirements. And so when they ask us for the stuff they ask us for, that's why they're asking for it. It's their policies and everything. So when we're calling them, sometimes we just have to go with it. Goals and objectives, y'all see them here. We're going to talk about a lot of different things, facts, figures, some risk factors why you get stones. We'll do a little Q&A. We'll go over some cases as well. Of course, we're going to have some ultrasound, right? And not quite as much as we did last week. And then we'll kind of go over some other just general topics with stones. So this is just a nice little chart of, what kind of stones are out there. About 85 to 90% of them are calcium oxalate or calcium phosphate stones. The other 5 to 10, there's a uric acid set, which that's kind of low, and then the magnesium phosphate stones, the Struvite stones, or the staghorn calcula stones. Cystine stones are a very small percent, and you can see up there, uric acid's kind of associated with gout. Calcium oxalate is one of those overexcretor issues, and then the Struvite stones, most of those are going to be infected stones, recurrent stones, and they kind of carry a high morbidity, mortality with them, and usually they're surgically intervened on. So the thing about stones is a small portion of people get them, about 10%. The problem is those 10% are repeat customers basically for life. I mean, they just keep getting them over and over again. So is there drug-seeking behavior? Maybe. Are they really having stone issues? Maybe. I mean, you got to fish that out. Somebody way back when I was, I don't know, maybe an intern, not that far back, but they were like, look, Lee, give everybody at least 30 seconds of kind of benefit of the doubt when they come in for whatever complaint it is. So if they come in with stones, even though they were there a week ago, at least give them the benefit of the doubt. I'm not saying you have to give them 180 percodoodles, but, give them the benefit of the doubt. So risk factors, who get stones? People with metabolic diseases, disorders, Crohn's disease, people with irritable bowel disease, Crohn's, ulcerative colitis, people that have had small bowel resections or surgeries. They're oxalate kind of overproducers or over secretors. So they kind of get the calcium oxalate stones from that. A bunch of other different things. Primary hyperparathyroidism is one that is fairly common out of all the things that are up there. Sarcoid is another kind of common one. Gout, people that abuse laxatives because, not laxatives, but have peptic ulcer disease and have a lot of alkali. They drink a lot of milk and magnesia and things like that. They'll wind up with stones. Family history is another indicator. Male, white guys more than black folks, and then previous kidney disease, and then dehydration. We all see that, especially in the summertime. So, question and answer part of this: what causes the Struvite stones, and what are they also known as? Any takers? So urease, splitters, Pseudomonas staph, Proteus, KLEB, and then staghorn calculi. I think this showed up on one of the in-services one year, I don't remember. So y'all know how they look, microscope under the microscope, not that we're looking under the microscope, and do they have a high or a low pH? Let's go with the pH question. So what are they made of? Magnesium phosphate. So they're going to be alkali. And they kind of have this coffin lid appearance is what they're kind of termed as, coffin lid. So pH more than 7.5. Urine pH typically is not more than 7 unless you're having some issues going on. So that's just kind of general rule of thumb. We already said this a while ago. Struvite stones do or don't need surgical intervention, and they do. And like I said, they're associated with a high rate of kidney failure and morbidity. And that has to do with their infected nature. So, most common cause of calcium oxalate stones? Anybody? Idiopathic, right? Most common cause of hypertension? Primary hypertension. What's the bigger player in calcium oxalate, the calcium or the oxalate? So years ago, they used to think it was calcium, so they would tell people to lower your calcium, do whatever you want. They didn't care about whatever you did with the oxalate, but lower your calcium. And they started having a lot of problems with that. So now they say, just leave your calcium alone and decrease your oxalate intake. What did I just say? False. So a nice little chart. So some more risk factors, low urine volume, low intake, dehydration, right? Hypercalciuria, hyperparathyroidism, anything like that, give you that. Hyperoxaluria, from whatever intake it is, a lot of protein foods, oxalate containing foods, that'll get you that. So how do these show up and what's their pH? What do they look like under the microscope? Well, let's start with the pH question since we didn't get the high or low. Low, right? Makes a little sense. We already said the other ones were high, so. And they have this kind of envelope appearance. So they're kind of squared off with an X across them. Or you could just say they look a little shorter than the other ones as far as the coffin lid goes. So differential, when we're talking about kidney stones, big differential, right? Most of these we kind of can just rule out as we're going through them in our head. Sometimes we have to think about if a female shows up with some kind of flank or kind of left lateral or right lateral abdominal pain, some GYN issues. The guy over 50, 55, 60, whatever your kind of threshold is, first time kidney stones, no history of kidney stones, you got to think about a AAA, right? It's a good mimicker. Pyelonephritis, this goes into what was the onset like? Was it gradual onset? Was it sudden onset? Do they have history of kidney stones, and did they start with pyelo and then wind up with a stone? So you got to think about all these things. Signs and symptoms, like I said, it's usually fairly abrupt. They'll tell you they woke up with it, or it woke them up at X, time in the morning, or they were doing this, and I mean they can recall when it started for them. It's intermittent, kind of colicky pain. We've all heard of that. And that's due to the peristalsing of the smooth muscle in the ureter and it trying to pass that stone. There may be a dull underlying ache, and that has to do with obstruction of the renal capsule. So when you start talking about the constant part of that, you might want to think about, well, is there an obstruction along with this colic? Typical migratory pattern is kind of flank lateral abdomen down into the groin. The more proximal the stone is, the less of that distal stuff you're going to have. The more that the stone moves down the ureter, the more of the groin kind of part of this you're going to have. Might have some urgency, frequency. So hematuria, most of the cases are going to have some hematuria, but about 15% or so will not have hematuria. Don't let that kind of lead you away from thinking that, if it's a stone. If it looks like a stone, quacks like a stone, smells like a stone, it more than likely is a stone. And then nausea, vomiting. Physical exam. So usually walk into the room. The people that have never had them before, the people that have never had them before are going to be writhing around in bed usually. The people that have had them, if they're having a really bad case of them, they'll be writhing around too. Abdominal tenderness is usually not a problem. They may be laterally or flank, but usually not abdominal. They may have some hypoactive bowel sounds, and they're probably going to have some CVA tenderness. Labs. So what are you going to get? Who wants to get a urinalysis with these? Just raise your hand. Everybody should probably get, that's kind of, you're going to get that. Who wants to get, we'll talk about the urine first. We don't do the microscopic part right when we order the point of care. You just get kind of the wet work, the dipstick. And that's okay if we're trying to kind of move these people through and we think it's a stone. And if it's not infected, that's not a big deal. Just know that, we talked about a while ago, there's no hematuria in about 15% of them. You may need a culture, okay? If you're doing your workup and you have some blood and then you have some small leukosterase or something, nitrites or anything, you may want to send it to the lab and let them do the rest of it. how many of you guys typically somebody shows up with some, what you think is, kidney stone? We'll talk about imaging later. How many of you guys usually get point of care, like a BMP, Chem8, creatinine? Huh? Yeah, so what? So like duration, what?
Depends what their ultrasound.
Okay, depends on what their ultrasound looks like, duration. I mean, if it just started today, you think you're going to see much on the BU and creatinine? Even if it's been going on for 2 or 3 days, probably not. Been going on a little longer than that, maybe so. Some of that too depends on kind of their underlying, kidney function. Do they have like stage 3 or 4, kidney disease? It's going to hit them a little harder than somebody else. This talks about, and this is out of Rosen's. None of this is like urologic or out of the urology literature, but Rosen's talks about, think about calcium, phosphorus. We typically don't. Calcium comes in the BMP, right? People that are hypercalcemic, you might want to think, well, do they have some underlying issue, right? Hyperparathyroidism or something like that. You may not work that up, or you may not, do anything with that, but it is something to kind of think about. And then the old CBC, right? How many of us typically get that? Nobody? Unless you're doing what? Phone call? And then that's the first thing they want to know. So imaging, non-con CT since about like 1995, 98 has become the more or less gold standard. It used to be an IVP and a KUB, but that has kind of gone by the wayside because non-con CTs they're quick, they're easy. You get a lot of other kind of views. You're looking at other things too. But, there's a radiation risk associated with that. I mean, they're good at picking up stones, but there's a fair amount of radiation involved. And the old estimates about stones that would pass was based off of KUB, the size of the stones on KUB. All that stuff has been kind of looked at again and refigured since CT has come into use. But the point is CT can kind of underestimate stone size. Ultrasound, not very good for actually picking up a stone, but it is very good for detecting what we care about if there's hydronephrosis, right? Because we're worried about what 2 things we're really worried about for kidney stones. Hydro, and then infection, right? Because that kind of changes management, what we do, inpatient, outpatient, who we're calling, who we're talking to. Ultrasound, we do tend to overcall hydro with ultrasound. And then KUB, usually if you do wind up in call GU, they're going to ask, did you get a KUB? It doesn't really make a difference for that stay, but the reason they want it is because they're going to use that to follow them in the clinic. That's kind of how they see how they're doing. And another rule of thumb that I kind of use is if these people tell you they have a J stent, I'll get a KUB just to see where it is, if it's displaced, dislodged, or if the stone's in there somewhere. IVP, very little utility these days for IVP. So who's going to pass stones? Where are they going to, most likely to pass? There's a kind of an inverse relationship here. Smaller stones have a higher rate of passage. Bigger stones obviously have a lower rate of passage. Kind of makes sense. Your proximal stones, once again, lower rate. Distal stones, once they've made it that far, tend to pass fairly easily. So, you got a big stone proximally, more than likely not going to pass it. You got a big stone distally, you're probably going to pass it. And this is all based on over the course of 4 weeks. So once again, it's our job to try to figure out, where these patients need to go. Do they need tight follow-up? And in this institution, this place, we're going to be calling GU more than you will when you're out of here in 2, 3 or so years, but that's just so that they do get follow up. Just just keep that in mind. So, recent literature that's out there. I think we had a journal club a while back about CT use and ultrasound use in stones. I don't know, and this is probably attending dependent, whoever you work with, but how many of you guys, if somebody comes in, a young guy with no other medical problems, tells you, it hit him out of nowhere. It's left flank pain. He's got, he says, I'm passing blood, and he's writhing around in bed. In a young guy, what's it going to be? Stone. What else could it be? Stone. What else could it be? Some other stuff, but maybe stone. What are you going to get? You're going to probably get the urine. It just happened today. You can get the BMP if you want to. I mean, that's kind of, your discretion. But this study, and it was a pretty good study, it was talking about that there's no real consensus about the imaging that needs to happen for these people. And we'll talk about it a little later. Younger people, some people don't get any imaging. People that have had stones, some people continue to get CTs. Some people that have had stones, you can just do ultrasound. It was a pretty good study. And basically, they looked at the 30-day kind of morbidity, mortality about the imaging that they got with these people. And what they did is they broke it down into bedside ultrasound, radiology ultrasound, and then CT. And basically, nobody had bad outcomes. And they kind of got everybody to the appropriate place that they needed to go to. And I'll spare you all the details. This isn't a journal club, so if you want to look at it, you can kind of read that. But the bottom line is ultrasound can kind of replace or kind of surpass in certain people, I think, a CT. And then this was one it kept popping up when I was trying to find this study, is kind of the ability for ultrasound to detect outcomes 30 days. And what they were looking at was hydronephrosis and ureteral jet. And basically what they found was ureteral jet didn't have any indication on kind of your morbidity or, any kind of outcome at 30 days, but that hydro did. And I forget the number of people, I think it was a fair amount. I want to say like 30% of those that had hydro wound up getting admitted. So that was a bigger indicator. So ultrasound, very good at picking up hydro, very good at kind of leading you in the direction you need to go about what you need to do with the patient with the complicated kind of stone picture. So, sir.
So, what is it with ultrasound that you're not getting in context of the basically what the size of the stone?
So you're not gonna. Right. I mean, ultrasound we got a couple of folks in the back too that we can ping this off of as well. But ultrasound is good at picking. Well, I say good. If it's a large stone, a fairly good sized stone, and Matt's here too. I thought he'd stepped out, but if it's a good sized stone in the kidney, you're probably going to pick it up, probably. Not always, but probably. We go back to that. It's about, I think it was 60 to 85%, at finding stones. You'll find distal stones a lot of times. You'll see them sitting right there at the bladder ureteral junction, or either in the bladder, and you can say, well, yeah, that was probably a stone. But it's those stones, the very small stones, the 1, 2, 3 millimeter stones, you really won't find those, and the ones in the ureter, you have a trouble finding. But once again, we're not really, so that's what you're getting with the CT. You're getting the stone, the location, or the size, the location is really what you're getting. And that's why urology is asking for it. One, it's in their guidelines. That's what they're asking for because that's what they know to ask for. And two, it gives them a better picture of what's going on. For us, it may not really matter, though, too much. Is that?
Yeah, I was just wondering because, at least my experience with, and again, I'm not in the ultrasound group, but a lot of times it's like hydro's about all I'm getting out of it, usually.
Yeah, for us it is. Yeah.
Is that enough? Am I happy with that? Well, I guess I am, but I guess for a first-time stone, I tend to still go ahead and get a CT just to document, partly because of the drug-seeking behavior. Sometimes it's like they came in, a month ago playing with a stone, they didn't have a stone. We've got to be a little bit more careful about giving this patient further details. No,
I mean, I agree. And like I said, I mean, if somebody comes in and if they're a young person or whatever, and it's a stone, I mean, they're sitting there holding their back and they're, been urinating blood for a day or something like that. I mean, it's probably a stone. Am I going to get the CT? Probably, just because of where we are in our patient population, and they wouldn't get one otherwise. And if you get the CT and they have a stone, that gets them follow-up with urology. But, we're kind of a different, I guess, population than you. I mean, you were in the community for, some years, Mike. I mean, what?
The community was fairly easy to get set up. If didn't necessarily need imaging on the first time stone with somebody with electronic here, doctor. You could say, this is a young, otherwise healthy person with hematuria and symptoms of renal colic. I'm going to treat him for kidney stone. We've got the pain control. Order an outpatient image, outpatient CT, the primary care follow up on it, or just refer the whole study to the primary care doctor. But there was a communication component to that entire process about talking to the primary and getting them to follow it up. Here, even though, I don't know, urology should work up hematuria. You do that. Have that before they show up. So part of that first time stone voodoo is really, what do you think you're going to be able to do? I do a lot more scans here on people with stones because I can't get them followed up otherwise.
Yeah.
Just one word about ultrasound or stones. You got to select the right patient. All right. So if it's a 75-year-old who's coming in with flank pain, and you think it's a stone, you're just going to do a renal ultrasound. The risk for other pathology is really high.
Yeah.
Right.
Yeah.
So this is better applied in the young patient population, someone you feel confident, even perhaps somebody with a history of kidney stone. It feels just like my kidney stone. You're doing that ultrasound just to document the state of renal dilation. I think that's where it's most applicable. Probably not for the elderly, high-risk patient, high-risk abdominal pain patient.
Yeah, I mean, if you're older, you're probably going to get a CT. And I was just fixing to talk about that. The older person, even who has stones, I'm probably still going to peek at their aorta with the ultrasound. Now, you may not, always be able to visualize it like you want to, but I mean, just somebody who's older, you always got to think about that AAA. So, I mean, in addition to doing your renal scan, if you're going to just do that, then I'd pop it on the aorta too and see what it looks like.
So one other point too, question I have for you is, do you have a sense why IVPs have gone almost, Mike, and those who have, used IVPs in the past, that was a very decent tool for picking up stones. This seemed kind of to cut off the contrast and all that. I guess the problems with IVPs is they just IV contrast. But I guess my point would be is if you're out there, your CT is broken down and you don't have ultrasound, IVP, it's a very useful, a very good imaging tool, I think, for stones. Anybody got any comments on that?
Part of it is they say you get more information from the CT scan about other things. And even though it's a functional study, it can take way longer.
Definitely takes longer. That's a good point.
It takes a lot of time and more effort for the technicians to do it.
Delayed films and
all those things.
Yeah. When I was looking at that those were the three things. One, you get more information with CT. Two, there's the contrast risk. I think it was, like it was 1 or 2% or something like that, or it might have been less. But those were kind of the kickers in why it's not really used anymore. And then CT is everywhere now. Even Burke and Scriven probably have a CT in the back closet somewhere.
we know like lumbar films have about as much radiation as a CT. I wonder if an IVP has fairly similar amount of radiation.
Yeah.
That you would expect there, but
It may, but they end up doing like 9 films.
yeah, right.
Just to get the functional part of it, so it's not like one more film, it's like 9 more.
Yeah.
Which is another thing to be aware of, because urology likes to follow plain field, and so it's not unusual when you get a CT stone proven that urology says we want a plain film to make it easier to follow.
Yeah.
You're giving that patient a lot, right?
You are.
You'll
And
be able to see that stone on the scalp film, with the CT scan if you're doing it here. If you can see the stone on the scalp film, it may be worthwhile to go ahead and say, when we see it there, you can follow it up on the plain film later on. But if you can't see it on the scalp film, there's really, common sense would tell you that there's not going to be much point in radiating again for a plain film.
See,
yeah.
I always thought that the data on KUB for stones said it was terrible. So I don't completely get follow unless you've documented the CT already, you know where it's at. But legal lifts and all that just kind of really confuse the picture. And so my understanding is that it's very not sensitive or specific?
It is. I didn't put it in here. I didn't include it because it doesn't change what we do. It's what they want. But the KUB, so 90% of stones are radio opaque. All right. The ones you're going to miss are the uric acid stones and the cysteine stones and those things because they're not radio opaque. So that's your kind of 10% that you won't pick up on plain film. But the KUBs, even with the oblique views that they get, or that they ask you for, it's like 70% success rate with finding a stone there. You're going to miss stones that are sitting right on the pelvic brim because the iliacs are going to cover them up. You got phlebolysis that cause problems. So that's the problem with the KUB, even with the oblique views, is it doesn't pick them up. But once again, it's one of those things. It's ingrained in what they want, and that's how they follow them in the clinic. And I think that goes back to why do they want the CT, so that they see the stone and they know it's there. Then they know on the KUB they can cheat and kind of look at it and see where it was, or is it, kind of do that with it. Back to ultrasound. So this up here is going to be just kind of a progression of what we're looking at. We've got some ultrasound images here of different stages of hydro, and then we've got kind of a little line drawing here, a little cartoon drawing of what you kind of are going to see. So this is kind of mild hydro. You've got a little bit of dilation right here in the pelvis and the calyces. Your moderate kind of hydro is going to be here. You've got a little more dilation, but the cortex is still kind of spared, so you don't have that cortical thinning that we always hear about and talk about. You get into these two down here, this is going to be kind of, I'd call this moderate to severe, and I definitely call this severe for sure. This is your kind of bear claw picture here. But you've got the calyces is just, it's dilated up. You obviously have an obstruction downstream somewhere, and now you've got this cortical thinning that's going on, and that's what's putting all the pressure on the capsule, and that's what's causing a fair amount of pain. It's also causing kidney damage too. These people are usually pretty sick by the time they get to you if they have some hydro looking like this. So here's a question. Somebody comes in and said, hey, I had the stone a week ago, and I had some hydro on my ultrasound, and I'm still having pain. What do you think you're going to find on the ultrasound? If they had stone pain for a few days before coming in and had it for a week, think you still see some hydro? Think it'll all be gone? Probably have a little residual hydro. It's kind of like a chest X-ray and pneumonia, right? Your chest X-ray is going to lag way behind the progression of your pneumonia a lot of times. So expect to see a little bit of hydro even down the line, even if they have passed the stone. So once again, this is kind of a mild picture, more moderate right here and severe for your hydro. Any questions about ultrasound hydro? Don't forget to scan the bladder. All right. Try to look for jets. Try to see it. Sometimes you'll see a stone sitting in the bladder stone. Not to say that it is the stone they passed. Bladder stones are a different kind of entity than kidney stones, but if they've been having kind of that colicky type pain with some hematuria and you see a stone sitting in the bladder, that may very well be the one that just passed down through the ureter. So indications for admission, and we kind of, I hate to say fight this battle, but we're on the phone a lot with our GU colleagues about, it shows some mild to moderate obstruction on either the CT or the ultrasound we got. We'll leave out the infected part, can you come see them? And a lot of times they're like, we don't need to see them, just see them in the clinic. And like Mike was talking about, that's probably fine in the community because they're going to see them and no problem. But here where we are, a lot of times people get lost to follow up. So don't forget, you're your patient's advocate for whatever's going on with them down in the department. If you feel like urology needs to come see them, have them come see them. If you kind of come to an agreement, think it's okay, you can probably see them, sooner than later. Take their information down. I'm going to give them a consult, give them your phone number. Then that's probably okay too, but don't forget to advocate for your patient. So obstructing stone, infected stone, changes your management obviously. All these things, the ones up here, let's see, down to kind of a hypercalcemic crisis, these are all kind of what they call then Rosen's an absolute indication for admission. which makes sense. Those are all, pretty bad things, and nobody wants to go home with pain like that. These significant comorbidities, high-grade obstruction, leukocytosis, stone size, were all kind of relative indications for admission. So what are you going to do for your patient? Well, what have you already done for your patient in the ED? You've addressed their pain. You've given them some fluids if you think they need some fluids. Once again, we don't always have to give fluids for kidney stones. There's a fair amount of literature saying that may not do as much good as we thought it was going to do previously. If you've got an infected stone, typically the go-to, and I did get this out of the GU literature, is AMP and GENT, and these are kind of the bugs you're covering for. Outpatient management, okay, this is a majority of what we deal with, right? Everybody's done plenty of this. You're going to give them some Zofran, Phenergan, something for nausea, vomiting. You're going to give them a strainer. Once again, doesn't matter for us, but it matters for urology or PCP, whoever they're going to follow up with. Yeah. So what they'll do is you'll give them the strainer. They'll catch it. A lot of times they'll miss it because they'll have this frequency and urgency, and they'll run to the bathroom, and before they know it, they hear tink, 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 tink. It's already hit the toilet, and they're like, I missed my stone. But if they catch it in the strainer, they'll take it back to their follow up, whoever it is, GU or primary, and they'll send it to the lab for analysis. They'll do stone analysis, and that's where they're coming up with all these figures of 85 to 90% are calcium oxalate or phosphate, and the others are the Struvite and everything. And back to imaging, Struvite stones at Staghorn, you'll see it on the CT. A lot of times you'll see Staghorns on ultrasound. I think the ultrasound, Matt or Eric or Rich, those will show up on the ultrasound. They're usually larger stones. They have a very irregular appearance, and a lot of times they're just sitting in the kidney, sitting there causing a lot of trouble. So Flomax or alpha blockers, whatever your alpha blocker of choice is for medical explosive therapy. This was a Cochrane review done, I think, 2014. So it's hard to argue with Cochrane reviews. They're saying that alpha blockers should probably still be offered, that they actually do shorten the time for stone passage. I know there's some literature that has been floating around out there that says they really don't do anything, but like I say, it's hard to argue with Cochrane. NSAIDs and non-opioids for acute renal colic. Basically, a lot of people, well, what if they have acute renal issues, acute renal failure? Well, I may spare them all the NSAIDs and everything, but don't not give people NSAIDs that come in with renal colic, especially to go home with. I mean, it's been shown to help a lot, and it helps with a lot of time. Well, one with the pain, inflammation too, but it has this kind of inherent antispasmodic effect on the smooth muscle in the ureter as well. And then opioids if you need to, because let's face it, that's what everybody comes here for, is their Percocets, right? Don't be handing out 180. So we'll go over some cases real quick, and y'all take a break. 32-year-old guy shows up with abrupt onset. It's left flank pain, some hematuria. He's in there kind of on the bed writhing around, but his vitals are okay. And they went ahead and collected a urine at triage, showed some small blood, nothing else. What else you want to know?
Had a stone before.
No stones before. First one ever. Or first time he's ever had pain like this ever. Nobody wants to know anything else?
Fever.
No fevers.
Check his finger. Did he prick it and drip it in the urine?
Thank you, Dr. Reed.
Oh, that never happened.
That never happens. So, well, this is off the subject a little bit, but we so often get point of care urines that we miss the microscopic part of the urinalysis. People that have pricked their fingers and drop it in the urine are going to have a lot of intact red blood cells on the microscopic part of their urine. People that have kidney stones, They're going to have some intact RBCs, but it's not going to be as much as somebody who pricked their fingers, okay? Because you're passing stone, you're lysing cells, there's a lot of trauma going down the ureter when you're going around that stone. So, is that an absolute thing? No, but just, keep it in the back of your head. But, all right, so we checked their finger and they didn't prick it. Anything else?
Didn't have any discharge.
No discharge. What there?
That was the same thing. Urinary symptoms.
Just a hematuria, and when it's some dysuria. When he goes, it seems to be worse.
No trauma.
No trauma.
No other medical problems.
No other medical problems. No, he's had some nausea. He might have thrown up one time, and it started today. Anybody want to do any labs other than what we've had at triage? Probably not really necessary. It started a few hours ago. He's otherwise healthy. Vitals look good. So is he dehydrated? Does he look dehydrated? Does he have poor skin turgor? Has he got skin? Huh?
After a couple hours,
Probably not. Or even if it's been going on a day. He's vomited one time. He's a young, healthy guy. And remember, dehydration is a clinical diagnosis. Sure, we look at creatinine, sure, we look at specific gravities and things like that, but does a guy have skin tinting and poor turgor? If he doesn't, then I would say clinically he's not dehydrated. Does he have nice moist mucous membranes and things like that? No, he's not dehydrated. Anybody want to do any imaging for this guy? How many no's? How many yeses? How many non-committals? All right. Like I said, there's getting to be more and more evidence that first-time stones don't necessarily have to have any imaging. They could have CT or they could have ultrasound. So kind of take your pick on that. So he did fine. Next case. All right, so we've got all this, right? 47-year-old with a bunch of comorbidities, flank pain, he's had stones before, it's febrile, small blood, moderate leukosterase at triage. What else do you want to do? Or what else do you want to know? Do we know enough?
CBC.
All right, we hadn't gotten to this part yet. What else do we want to know? Anything? We got to talk to our patient, right? We got to put something in the chart that we actually saw the patient, not just lab work and scans. He takes some colchicine every now and then, but not all the time. When he thinks he needs to.
Lightheadedness, dizziness.
So he's had some nausea, a little bit of vomiting, but no real dizziness or lightheadedness.
No abdominal pain.
No, well, we'll say it's all right flank pain. Yeah, it's all lateral pain.
No chest pains.
No chest pain. Mm-mm. He tells you, hey, this started out kind of vague pain, but then I've had this kind of intermittent pain where it just stabs me in the back, and then it goes away.
Radiated?
Just down into his groin. That's it. Just like his previous kidney stones. He's a pretty good historian. Not our typical patients.
And no urinary symptoms.
No other urinary symptoms. Anything else we want to know? Ask him.
How's he look?
So, he's in a little bit of pain, but he's uncomfortable appearing, but not writhing around in the bed. He every now and then says, I feel a little queasy. He'll kind of, grab his epigastrum from the queasiness.
Is he a smoker too?
We'll say he's a smoker.
Yeah.
What else do we want to ask him?
Take that insulin?
is his diabetes controlled?
What are your blood sugars at home, man? Yeah.
I'll check my blood sugar.
Yeah, that's what you. Yeah, blood sugar. What is that? I ran out of strips 3 weeks ago. I don't know. So a good question generally to ask any diabetic, whether they have cellulitis or UTI or stone, anything, is what are your sugars at home? So he's like, they usually run in the 150s. They've been in the 300s, over the last few days or so. All right, so we got probably enough information. He's got some CVA tenderness on exam. He's febrile, obviously. What do we want to do down here? Labs, imaging. What do we want to do for him? All right, we're going to give him some. We're going to treat his pain and do all that. Do we want to give him any fluids? Yeah, sure. We'll give him some fluids. Well, his vitals are.
Start him on antibiotic.
All right. Let's do this. What labs are we going to get? Well, stepwise progression. CBC, urine culture, chemistry, and how about a full-on UA, dipstick micro, and then what else we want to get with that UA? Culture. All right. So what's this guy's probable path? Infected stone, admission, discharge. Admission, right? I mean, we got a diabetic with a bunch of comorbidities. He's febrile. He's not ill appearing, but he doesn't look great either. All right, so we're going to get all that stuff, and what kind of imaging we're going to get? Okay. Okay. I mean, he's 47. I mean, he does have some other stuff. He is a smoker, but he's not an old guy, and this reminds him of Stone. So we got a vote or two, or maybe three. I don't know. Who wants to get ultrasound? At least first. All right. Say we see some hydro on there. Anybody want to go further with a CT? Yeah, unilateral. We got some people in the back that want to get a CT. You want to ask them why they want to get a CT? He could have other things too. I would argue get the ultrasound first. If you see some hydro, I'm done. Does your consultant want a CT? Probably so. What are some things you're going to find on CT potentially in somebody like this? What else could they have? I mean, he could have bad things like some extravasation, urinary extravasation. He could have perfed one of his ureters. He could have an abscess sitting right there around there. It's been cooking for a few days. He's a diabetic. His sugars are out of control. I mean, he could have other bad things that you may not see with ultrasound. So getting a CT would.
Hey, so Lee, though, I would argue that if this guy has a huge stone, high grade obstruction, he's got chronic kidney disease already. I mean, he doesn't have much kidney left anyway.
Mm-hmm.
I would go for a CT because I would want to rule that. I mean, if he needs more of an aggressive intervention, that's kind of what I was thinking.
Yeah,
I'm thinking the same thing. If this guy needs to get a ureteroscopy or something, I need a stent or something, but you're going to need to get some fairly substantial evidence for what's going on before the urologists are going to go ahead.
Oh yeah, I mean, this guy's going to wind up with a CT, no doubt. But I mean,
If he has zero hydro and he looks great and all he has is an infection, he doesn't meet both obstruction and infection, which is what urology goes by for admission. So you could send him over post follow-up.
I think you could call your urologist and say, this is what we have on the ultrasound, whether you do it or you send it to, I advocate you do it, but whichever way that goes, he has no obstruction on ultrasound.
Could I add one
What do you
point?
want to do?
In case you missed it, you may have said it, and if you did, just throw a shoe at me. But remember, a lot of these folks, they come in vomiting and dehydrated. So they may not have hydro in your initial ultrasound. So I wouldn't rely on that to always rule out a stone. If clinical suspicion is high, then they have to advance to other imaging. So remember that.
Hey, that leads into another question though. There's some people think that, I'm going to just give them 3 liters of fluid and I'm going to just pop that stone right out of there. What's your thoughts on that?
There's a lot of literature saying that it used to be the thing, solution to pollution was dilution, right? That's kind of not really been shown to kind of pan out as well as we thought it is, as far as the expulsion part of it. They're saying hydrate them, give them fluid, but not necessarily hammer them with fluid. You can cause a little more harm than good sometimes with that. Yeah, I would say if, like Rich was saying, if they're severely dehydrated, which this guy, I mean, he looks like he's probably okay, maybe a little dry, but, he hasn't been, vomiting his head off at home. But, give them some fluids. I'm not, don't say don't give them fluids, but yeah, you can actually cause a little more harm than good with that.
Years ago, that was kind of, and I think Janiac and I have had this conversation, but that was kind of my philosophy, lots of fluids, but then after a couple of AOCs would pop, you get see contrast, extravasation, say, oops, I don't think I'm going to do that.
Yeah. All right, so I think we kind of beat I mean, this guy's going to wind up getting all the imaging, all the stuff and everything. So we're going to give him some antibiotics. We're going to call our friendly urologist, and hopefully they'll admit him.
Lee,
Sir.
when you said CT, I'm assuming you were talking about just like a stone hunt CT.
Yeah, just a stone hunt, just a non-con.
They don't think you're carrying it for gas tests and stuff. So, of course, he's also got chronic renal disease, which is checked probably above the magic, whatever radiologist number decided
Probably.
on that particular day, that particular hour. So, if you get a close on the size of the stone, let's get a CT scan that's even remotely passable. It's going to have to be surgically removed. So you are going to get a little additional information on CT.
Oh, that's what I say. This guy's going to wind up getting a CT. There's no doubt. He's destined for one for sure. All right. So case 3. Yeah, right. 55-year-old guy, got some left flank pain, never had stones. He's a smoker, got some high blood pressure. His vitals look good though. UA has some moderate blood. What else you want to know?
Is that him in the picture?
The younger version of him. That was the younger version of him. Want to ask this guy anything else? Physical exam? Anything? All right, so no pulsatile mass. That's only in textbooks.
Any bruise?
It's too loud to hear any in the ER. You got patients screaming in A1. You can't hear anything. So, all right, so no bruise, no pulsatile mass. So good, y'all are all thinking about, things that, you could find on physical exam for this. So, he tells you sudden onset, it's left flank. I got a little bit of abdominal pain, but not too much. You press on his belly, it's just kind of mildly tender, not peritoneal by any means, or no peritonitis signs. And I don't know, that's about it for him. Any labs? All of them, probably, right? I mean, we're thinking about other entities now besides just a straight up stone. So you're going to get, the usual things: CBC, BMP. You're going to get a urine too, probably, because now we're looking at the U8 triage, point of care, moderate blood. Well, we don't know what else it has in it. It could have some other stuff in it too. Imaging for this guy, what's he going to get? I mean, you can start with one, but what's he going to get to? He's going to get a CT. You're going to get a non-con or a con? Huh? What's the most likely thing he has? What's the most deadly thing he has? Okay. Could have a dissection. Somebody heard dissection out there. He could have it. So, you got to keep that in mind. Why could he have moderate blood in his urine? Besides the, kidney stone? What do dissections do? Yeah, so they dissect that. Where are most aneurysms in dissection? Or most aneurysms are infrarenal, so they'll dissect right up through the aneurysm, will get dissected right up through the renal arteries. All right, so this guy's going to get all these things. You find out it's just a stone. What do you want to do with him? You control his pain, inpatient. Urine's negative for anything else. Okay, I'm wrapping up. We got one more. That's it.
So you said it was positive for stone?
Positive for stone. He got a big old stone, but it's very distal. And no stranding, no infection, nothing else in his urine. So.
A couple medications in the urine stream.
All right, so our last one, 55-year-old guy. He's got some history of stones. This is basically the opposite of the other guy. He's got some moderate blood. What else you want to know? It's on exam, it's a stone. No belly pain, no tenderness, got some CVA. Anybody want labs? All right. Labs and a bedside ultrasound. Creatinine's normal. Does that make you feel better that his creatinine's normal? What that slide way back a while ago said? The other kidney can compensate up to, yeah. But it gives you a little bit of something. So. Imaging for this guy, who wants to image him? He's like, it's been about 4 years since I've had a CT.
Well, I would do a bedside ultrasound.
Okay.
Why did you have a CT 4 years ago?
3 or 4 years ago for stone.
Oh.
He's had stones, known stones. So, I mean, I'd argue, get the urine. He's got some blood. Probably send it for the lab. See what else it has in it, and get your BMP with your creatinine in it. I'd do a bedside ultrasound if he doesn't have hydro and he's not clinically badly dehydrated like Rich was talking about. I'd probably call it a day. If you can control this pain and send him home, get him some follow-up. He probably has follow-up.